Rheumatic fever. What is rheumatic fever? Rheumatic fever is an inflammatory condition that can be in response to streptococcal pharyngitis, particularly group A beta hemolytic streptococci. Particularly group A beta hemolytic streptococci. So, all of this starts with a person having sore throat, which is caused by streptococcus pharyngitis, which is actually an immune response which is generated by our own body to tackle the antigens which have entered the body. And also, obviously, this can be treated by antibiotics also. Now, here is the thing, 97% of the population respond properly against the bacteria, while the rest of the 3% of the population will have a condition where the antibodies are not only formed against the bacteria but also formed against the tissues in our own body which have protein structure similar to that of the bacterial protein. That means antibodies are formed not only against the bacteria but also against some tissues in our body. Now, the group A beta hemolytic streptococci, particularly the Streptococcus pyogenes, which is pus forming, causes the pharyngitis. Streptococcus pyogenes has an M protein, which is an antigen towards which our body starts an immune response. This results in increased blood flow, increased permeability. This happens so that more and more amount of immune complex cells occupy that particular area. Now, as the M protein is recognized by the MHC2 complex, antibodies are formed against it. In 97% of the cases, the problem resolves. But in 3% of the cases, as we mentioned earlier, these antibodies also act upon the own self tissues of the body, which mimics the M protein on the bacteria. This is called as molecular mimicry. Molecular mimicry is when the antibodies formed in our body act upon our own tissues and cause destruction of the own tissues because these tissues resemble the proteins on the bacteria. This is molecular mimicry. And these 3% of the population generally includes children of 5 to 15 years of age group, poverty, overcrowding. So where are these tissues in our body and what are the proteins that mimic the bacterial M protein? One is in the skin, that is the keratin. Another one is in the basal ganglion, that is the gangliocytes which cause synonym scoria, which we'll discuss later. The laminin, tropomyosin, myosin, actin, troponin proteins which are present in the heart resulting in pancarditis. Another one is vimentin protein. Vimentin protein is present in synovial joints which results in polyarthritis. All these proteins resemble the M protein, hence antibodies act against these proteins. Now we will be studying this in detail. Now let's move on to the heart. About 50 to 60% of the patients with rheumatic fever would present with rheumatic heart disease. Rheumatic heart disease affects all the three layers of the heart. First, the pericardium, which has a visceral layer and a parietal layer. And there is pericardial fluid between them. So these pericardial layers are inflamed because of the inflammation of the epithelium. The pericardial layers are inflamed because the epithelium there is inflamed. So whenever there is a systole or contraction of the heart, the visceral and the parietal layer come close together and touch each other, resulting in intense amount of chest pain. This is called the pericardial friction rub. This is called as the pericardial friction rub. The next layer is the muscular layer, that is the myocardium of the heart. It is responsible for pumping the blood out of the heart. In rheumatic heart disease, this myocardium is inflamed and presents with fibrinoid necrosis. And also, there are many inflammatory cells occupying the myocardial area and these are called the Ashkoff bodies. There is fibrinoid necrosis and also there is presence of inflammatory cells called Ashkoff bodies. These are non-contractile. Because of this fibrinoid necrosis, this results in increased fibrin content and the Ashkoff bodies which cannot contract, there is a decrease in the contractility of the heart. That is, because of the presence of the increased fibrin and Ashkoff bodies which are non-contractile, the heart cannot contract to its fullest. Okay, so there is decrease in the contractility of the heart. This results in serious problems. What are the problems? There is decrease in the preload. That is, what is preload? Degree of stretch of the heart. There is decrease in the preload. The contractility is also decreased. Because of this, the stroke volume is decreased. And because the stroke volume is decreased, there is decreased cardiac output. Decrease in the cardiac output results in congestive heart failure. We certainly do not want that to happen. The last thing is that it can affect the endocardium also. That is, it attacks the valves. There is edema of the valves, vegetations on the valves, which results in stenosis and also regurgitation. Which valves are affected? The mitral and the aortic valves are generally affected. If this condition persists, it may lead to subacute bacterial endocarditis. Now let's move on to the brain. In the brain, there is something called as lentiform nucleus, caudate nucleus and subthalamus, which are concerned with upshooting, downshooting of motor movements. In the brain, there is something called as lentiform nucleus, caudate nucleus and subthalamus, which are concerned with upshooting, downshooting of motor movements, resulting in smooth motor movements in our body. If these areas are affected, which generally occurs in 3% of the cases, this results in syndrome scoria. In syndrome scoria, there are uncontrolled rapid jerky movements of the face, the tongue and the upper limbs. In syndrome scoria, there are rapid, uncontrolled jerky movements of the face, tongue and upper limbs. Next thing that we know is it attacks the joints. This is really very important as these are the first signs which are seen in the patients with rheumatic fever. Rheumatic fever can occur 1 to 4 weeks post streptococcal pharyngitis. Rheumatic fever can occur 1 to 4 weeks post streptococcal pharyngitis. Usually the first signs seen are fever and joint pains. This is why this aspect is most important. In 75% of the cases, there is polyarthritis because of the vimentin protein which we discussed earlier, which mimics the M protein of the bacteria. Generally, the large synovial joints are involved. Large synovial joints are involved, such as the hip joint and the shoulder joint. And this polyarthritis is migratory in nature. That is, the pain is not isolated to a particular area. The pain is migratory in nature. Now the last thing here is the skin. What happens here is there is concentric annular rash developing on the skin. There is concentric annular rash developing on the skin, which is also called as erythema marginatum. It occurs on the extremities and the trunk of the body. It occurs on the extremities and trunk of the body. Around the subcutaneous tissues, there are some collagen deposits seen, which form nodules. In the subcutaneous tissues, there are some collagen deposits which form nodules. These are called subcutaneous nodules, which are formed on the back of the wrist, the elbows and the knees. So now, how do we diagnose rheumatic fever based on our clinical presentations and knowledge? In this case, what we do is we follow a specific criteria called as the Jones criteria. What this criteria says is that in order to make a diagnosis, there must be either 2 major criteria or 1 major plus 2 minor criteria. There must be either 2 major criteria or 1 major plus 2 minor criteria. We will see what that means. A nice and easy way to remember the major criteria is by remembering the mnemonic Jones, where J stands for joints, which means polyarthritis. There is inflammation of the joints. Remember O as myocardium, that is the heart, which shows pancarditis. N stands for nodules, that is subcutaneous nodules. E stands for erythema marginatum. S stands for syndrome scoria. These are the major criteria. Now let's see the minor criteria. It includes fever, arthralgia, prolonged PR interval, and as the time increases, there is valvular dysfunctioning of the mitral and aortic valve in particular. there is increased C-reactive peptide levels. Increase in the C-reactive peptide levels. Increase in the erythrocyte sedimentation rate. Increase in the erythrocyte sedimentation rate. There should also be evidence of post-streptococcal infection. Evidence of post-streptococcal infection can be determined by rapid antigen test. Let's call it RAT, which should be positive. We can also do culture sensitivity test, which should also be positive. Next is, we will look for anti-streptolysin O titer elevation. We will look for anti-streptolysin O titer elevation. So again, there must be two major criteria or one major plus two minor criteria present to make a diagnosis of rheumatic fever. Now let's see the investigations. Investigations include chest x-rays, which show cardiomegaly, pulmonary congestion, echocardiogram, ECG showing sinus tachycardia, first degree AV block, elevated ST segment. Now let's see the treatment. Treatment of rheumatic fever is divided into primordial prevention, primary prevention, secondary prophylaxis and tertiary prevention. The primordial prevention include preventing overcrowding, improving the sanitation, then giving a group A beta hemolytic streptococcus vaccine. The primary prevention include the treatment of group A beta hemolytic streptococcus pharyngitis by penicillin or cephalosporins. The secondary prophylaxis include prevention of recurrences of acute rheumatic fever. Tertiary prevention includes medical and surgical management of rheumatic heart disease. So now let's see how the management goes. First, bed rest is required till ESR gets to a normal level. Anti-inflammatory drugs like aspirin 90 to 120 mg per kg per day in 4 to 6 doses for 2 weeks is given. This helps in treating the arthritis. Treatment of congestive heart failure includes complete bed rest and oxygen, prednisone for severe carditis and digoxin if indicated. Sydenham scoria is usually self-limiting. For severe cases, phenobarbital can be given. Patients with rheumatic heart disease and valve damage require single dose of antibiotics 1 hour before surgical or dental procedures to help prevent bacterial endocarditis. Surgical procedures are done if the heart failure persists. Surgical procedures are done if the heart failure persists or worsens after aggressive medical therapy for acute rheumatic heart disease. Surgery may be life-saving in severe conditions. Procedures such as mitral valvulotomy, percutaneous balloon valvuloplasty, mitral valve replacement can be done. Thank you.